So good morning, good afternoon, or good evening, depending from where you are joining us. Tonight, the IVPN NeuroPsychiatry, supported by Novartis, is organizing the first NeuroSTAT series, our one-of-a-kind learning experience. And during this educational activity, you will learn about neurology from the clinicians and the biostatisticians' perspectives. Our first NeuroSTAT webinar will discuss the comparative efficacy of disease-modifying therapies in multiple sclerosis and network meta-analysis. In fact, effective treatment of patients with MS requires an understanding of the comparative efficacy and safety of different DMTs. And direct comparisons through head-to-head trials between therapies in MS have not been conducted. Therefore, indirect treatment comparison through, for example, network meta-analysis are needed to inform us about the relative efficacy of a certain therapy. Before introducing our first speaker, let me thank Novartis for always supporting such innovative educational activities. Our keynote speaker for tonight is Professor Bassem Yammout. Professor Yammout is currently the director of Neurology Institute and MS Center at Harley Street Medical Center, Abu Dhabi, UAE. He is also a professor of neurology at the American University of Beirut Medical Center. He received his training in neurology at the University of Cincinnati, Ohio, followed by a fellowship at the Montreal Neurological Institute at McGill University. He was also the head of clinical research at the MS Center. He is currently the president of Menactrums, fellow of the American Academy of Neurology, and member of the Multiple Sclerosis International Federation International Scientific Advisory Board, and a member of multiple regional and international MS advisory boards. Professor Yammout is one of the leading experts on multiple sclerosis in the Middle East, with recent research on epidemiology, quality of life of patients in the MENA region, treatment, novel therapies such as stem cell and venous stenosis, and the impact of war on MS. In addition, he is currently the principal investigator on several ongoing international MS trials. Professor Yammout has authored many research and review papers and is currently the chief editor of the MS newsletter MS Today and on the editorial board of the Multiple Sclerosis and Related Disorder and Pediatric Neurology Journal. Dr. Yammout tonight will compare the efficacy of different disease-modifying therapy for the treatment of relapsing remitting multiple sclerosis. Professor Yammout, you are always the most welcome. You can start your presentation.
Thank you, Maya, for this kind introduction, and thanks for Novartis for inviting me to be there with you tonight. Let me start by sharing my screen.
Okay.
So these are my disclosures first. We've done very well in managing MS over the last 25 years. And I always like to present the study from a single Italian center, a study by Maria Pia Sormani, where they looked at their MS patients from the 80s till the current times and looked how did they progress, or how did they improve with all the current treatments. If we look here, this is the age of the patient versus the time to reach probability of reaching EDSS-6, which is walking on a cane. And if you look at the patient that were in the 80s and 90s before any treatment, which is the blue line here, we can see that by the age of 50, 40% of MS patients were already on a cane. Then came the interferons in the 90s. And if we look here at the 1996 to 2000 patient, we can see that at age 50, maybe 25% were on a cane. And finally, after 2010, we had all the new high efficacy medications. And looking at the red line here, at age 50, less than 5% of patients with MS are on a cane. So it's a huge advancement over 25 years, reducing the risk of reaching by age 50, walking in a cane by almost 85%. And I think this is the most rapidly evolving therapeutic area in all of neurology. So how did we achieve this? We achieved that by changing our concept of MS and learning more about the pathophysiology of the disease. It all started with the TRAP paper back in around 2000, where TRAP showed that most of the inflammation and the axonal loss occurs in the first few years of the disease. So most of our axons in MS are lost during those first few years. And this is what really leads ultimately to the disability accumulation years or decades later. So the first concept here was to treat early, suppress the inflammation very early on, and therefore preserve the axons and prevent disability on the long term. And this was later shown over the last few years by clinical studies that confirm this pathophysiological concept. This is the famous MS-based study looking at patients that were started on low efficacy medication versus high efficacy medication from the beginning as an initial treatment. And we can see that after 9 years, patients that were on low efficacy medication, like for example, interferon glutamate acetate, had a higher rate of progression into secondary progressive MS compared to the patients that were started on the monoclonal antibodies. Another example of this concept is comparing the Swedish to the Danish registry. In Sweden, many patients are started on high efficacy medication from the beginning, while in Denmark, most of the patients, the vast majority, like almost more than 90%, are started on low efficacy medications and escalated later on if need be. And if we look at those two graphs between Denmark and Sweden, we can see that patients in Sweden are doing significantly much better. And after 6 years, they have much less disability progression and less relapses. So all of those studies are showing, and these pathological studies and the clinical studies are showing, that we have to treat very early, aggressively, high efficacy medication, suppress this inflammation. And this is what will make the difference in the future of our patients. And this is exactly the Italian center study, what it showed, changing from the early 90s to the current times. Now, the problem with high efficacy medications in the past was their safety. With higher efficacy came lower safety. And we were talking at that time with natalizumab and the PML risk, cyclophosphamide and the significant toxicity, mitoxantrone and the risk of leukemia and cardiomyopathy, and so on. But this has changed over the last few years. Nowadays, we are lucky that we have now high efficacy medication that actually have a very good safety. So the efficacy safety balance has shifted significantly over the last 10 to 15 years to the point where we can now safely use a very high efficacy medication early on in the disease without worrying about the long-term safety. And one of those medication, one of those disease-modifying therapy with such a good efficacy safety balance is actually ofatumumab, one of the new B-cell depleting therapies. I'm going to talk a little bit about the initial trials of ofatumumab, presenting some of this data. Ofatumumab has been studied in 2 phase 3 trials, the Asclepios 1 and Asclepios 2, and these were randomized controlled trials versus teriflunomide, so an active, actually approved disease-modifying therapy. And it showed that ofatumumab was significantly superior in efficacy to teriflunomide. If we look here, the annual relapse rate was almost double on teriflunomide compared to ofatumumab, 0.22 versus 0.11, with a 50% decrease in relapse rate, and even Asclepios 2 up to 60%. A 0.10 to 0.11 annualized relapse rate, meaning a relapse every 10 years. This is how low it came. And if we look at the GAD-enhancing lesion, we can see, and this is what we've seen with all B-cell depleting therapy, almost complete suppression of any GAD-enhancing lesion. We can see here the number of GAD-enhancing lesion occurring on teriflunomide and almost zero GAD-enhancing lesion on ofatumumab. The effect on the confirmed disability worsening was also superior, and this is the combined pooled analysis of the Asclepius 1 and 2. And we can see that there is a decrease in the risk of disability progression by almost 1/3 when we compared ofatumumab to teriflunomide. And finally, we had this new concept, one of the new concept in MS treatment that we've seen over the last few years, which is the concept of PIRA, which is progression independent of relapse activity. And this was, if you remember well, it has been discovered for the first time during the initial OPERA trials, which were testing ocrelizumab, another B-cell depleting therapy. And it was discovered at that point in time that actually most of the progression early in relapsing remitting MS is not due to relapses not recovering well, but actually due to a silent progression of disability independent of relapses. And we've seen that actually in the Asclepius trials. If you look here, for example, for patient on teriflunomide, we can see that the disability worsening overall, most of it is actually PIRA, and a very small part or proportion is due to disability due to relapses. And the same actually for ofatumumab. Now, if you can see, the difference in ofatumumab between the total disability worsening and the PIRA is very minimal, because most of the disability due to relapses has been suppressed by the high efficacy, the high anti-inflammatory efficacy of ofatumumab. But still, the point behind those slides is that most of the disability early on in MS is due to PIRA. And this was really very worrisome initially when we knew about it, because the question is, if there is a disability ongoing independent of relapses, can we really control it by anti-inflammatory, or is it really a degenerative process that will not respond to anything? The first study that showed that it's not the case, that actually a high efficacy anti-inflammatory drug can suppress PIRA, was in the OPERA trial, where it was shown that ocrelizumab was superior to interferon in suppressing PIRA. And now here we have the second proof that early high efficacy medication are effective against PIRA, that PIRA is still probably driven by some inflammatory process, not a pure neurodegenerative process. And if you look at the Asclepius trials, we can see clearly here how superior ofatumumab is to teriflunomide in suppressing the PIRA. So suppressing PIRA early on is probably one of the main reasons why we would use a high efficacy medication even early on, because this initial PIRA that is accumulating will ultimately show as a disability which is irreversible later on. And this is not better shown than in this study. Sorry, we missed a slide here probably. But anyway, the slide missing here was showing that in the Asclepius trial, in patients that were on teriflunomide, of course, they got more disability worsening by the end of the years compared to ofatumumab. But once those patients were shifted back to ofatumumab from teriflunomide, the curve never met. So even after 5 to 6 years, the patient that had disability progression the first year on teriflunomide still showed a higher disability later on. So whatever axons were lost early on because of the lower efficacy medication was never gained later on. Finally, ofatumumab achieved a very high NIDA-3, no evidence of disease activity, so no progression of disability, no relapses, no new MRI lesions. And we can see here, if we skip the first 12 months, because it takes time for the medication to start working, at least the first few months, if we look between months 12 and months 24, so the second year of the trial, we can see that almost 90% of patients on ofatumumab are actually in NIDA, compared to around 50% on teriflunomide. So 9 out of 10 patients on ofatumumab at the end of 2 years are not showing any evidence of disease activity, which is really the outcome we want to achieve nowadays with our high efficacy medications, basically achieving NIDA. Now, how do we compare the different disease-modifying therapies as far as efficacy? Of course, scientifically, we cannot compare different trials, but in this meta-analysis, and the Professor Dimas will probably explain more how we carry these meta-analysis in the second presentation. In a meta-analysis of all the studies comparing all the disease-modifying therapy, we can always see that the monoclonal antibodies come on top as far as efficacy. And this has always been reflected in our Minactrim guidelines, where the highest efficacy medications used for the most aggressive form of MS are always the monoclonal antibody. As we can see it here, the 4 monoclonal antibodies have the highest efficacy when it comes to relapse rate. And again, we see the monoclonal antibodies on top of the efficacy chart when it comes to disease-modifying therapy, to disability progression. Now, another interesting thing that came again over the last 1 or 2 years, and is specific not only for B-cell depleting therapies, but probably for many other treatments, like cladribine and natalizumab, is the effect of body weight. And this is why, for example, cladribine is being always used based on body weight. And I think this is going to be the direction in the future for most of the MS disease-modifying therapy, going by body weight. And I'm going to explain why. If we look here at this analysis of the patient on ofatumumab in the Asclepios trial, we can see that whatever the body weight, whether less than 60 kilograms or more than 84, there is always complete suppression of the B cell. We can see here the B cell count dropping immediately within the first week by almost 80–90%. So very rapid onset of efficacy. And then by 4 weeks, it's at 0 and stays at 0. Why? Because we have monthly injection of the B cell depleting therapy. And because of this continuous treatment on a monthly basis, there is no recovery of the B cells at all. Now, this is not the case, for example, with ocrelizumab. And this is a study just published actually earlier this month by Professor Hauser, looking back at the OPERA and the oratorio trials of ocrelizumab and looking at the patient based on their BMI, their body mass index, and their weights. And if you look here at the first paragraph, they looked at the patient that had a very low BMI, less than 22, so very thin people, and a very high BMI, Q4, patient with BMI above 28.9, so not obese, but high weight patients. And when they looked at the efficacy of the medication on disability progression, it was obvious that the patient that had the lowest BMI, the very thin people, showed a very high efficacy and very low disability progression. While the obese patient with a high BMI actually showed a disability progression almost comparable to the interferons here, which are these 2 lines. So as if with the higher body weight, you might be needing probably a higher dose to really suppress the B cells. And when they look at the oratorio, which you remember is the ocrelizumab trial in progressive MS versus placebo, again, we saw the same thing. Thin patients showed a much higher efficacy of the medication with lower disability progression, while the obese patients, the effect was actually close to placebo at the end. And I put these 2 charts here, first for the relapsing remitting MS patient down here, and we can see that you are crossing the lines here in patients that are obese and have low exposure to the medication. Actually, there is no statistically significant difference in the disability progression between interferon and ocrelizumab. The superiority of ocrelizumab to interferon occurs only in the patient that are thinner with the lower BMI. And the same applies for progressive MS. Only the patient with the lowest BMI actually showed superiority mostly to placebo. And the reason probably is because ocrelizumab is given every 6 months, and therefore this B cell depletion cannot always be maintained, and some patients start recovering some of their B cell by 6 months. So let's keep that in mind, and I think the future of MS therapy is going to go in that direction, deciding on dosage of treatment based on body weight. So this is as far as efficacy. How about the safety of ofatumumab? As I mentioned before, ofatumumab, like the other B cell depleting therapies and many other new disease-modifying therapy, they have an excellent safety balance. And this is now we are more and more aggressive in using these high-efficacy medications early on to benefit our patient. So if you look at the Asclepios 1 and Asclepios 2 trial, we can see that the adverse event profile is very similar to terflunomide. And remember, terflunomide is one of the very safe medication in MS with very minimal side effect, very minimal rate of serious infection, and actually no PML case reported. So for ofatumumab, a B-cell depleting therapy, a monoclonal antibody with such a high efficacy, to have a similar safety profile to terflunomide, This speaks for the degree of safety of this medication. And if you look here at the different adverse event, comparing again ofatumumab to teriflunomide, looking, for example, at infection, nasopharyngitis, very similar rate between the two. Urinary tract infection, again, very similar rate between the two. If we look at the injection site reaction, of course, they do occur in patients on ofatumumab, but usually they are very mild and mostly within the first injection, as we can see here. 14% will have a first injection reaction. And then this rate of injection reaction goes down very quickly with the second and third injections. Now, we also have a long-term follow-up after the Asclepius 1 and 2 and other ofatumumab trials. They pulled all those patients together and followed them on the long term by shifting them all to ofatumumab. And interestingly enough, we can see here, for example, that patients that were on teriflunomide initially in the Asclepius, and this is the annualized relapse rate, and were shifted to ofatumumab at this point, we can see the significant drop in relapses, almost more than 70% reduction in relapse rate just by shifting from teriflunomide to ofatumumab. And if you look, of course, at the GAD-enhancing lesion, you have significant GAD-enhancing lesion by teriflunomide here. You shift to ofatumumab, and there is almost complete suppression of any new MRI activity, very close to zero new GAD-enhancing lesion. And this is actually the slide I mentioned initially, and that when we look at the disability progression between teriflunomide here and ofatumumab, we can see that at the end of the first 12 to 18 months, there's a significant split of the curve, with many more patients on teriflunomide being disabled. Unfortunately, if we shift all the patients here, which we did to ofatumumab, and follow them for 4 years, ultimately, this curve become parallel. So basically, disability progression on ofatumumab is similar in both groups. However, because of this early disability accumulation, they keep split all the way up to 4 years. And we can see at the end of 4 years, we have significantly more disabled patients that took teriflunomide in the first 2 years compared to ofatumumab. And this is really the main concept that I mentioned initially, the TRAP paper, the PIRA concept, the high efficacy medication used early on is very well shown in this graph, that if you lose your axons early on here during those first 2 years, you will never recover them. Of course, B-cell depleting therapy have been known to deplete immunoglobulin, and the important immunoglobulin for us that is related to infection is really IgG. And if you can look here over 4 to 5 years, the rate of IgG level in patient on ofatumumab did not decrease significantly. And remember that this is the lower limit of normal, which is around 6 to 7 for IgG, and the mean was always above that. And we had very low rate of patients that dropped below the lower limit, around 2 to 3% for IgG. And a very low number, almost 0.1 to 0.2% of patients that actually stopped ofatumumab due to hypogammaglobulinemia. The effect on the lymphocyte is very minimal. The effect on the neutrophils is also very minimal, with very minimal decrease in both count, as we know. And finally, the incidence of malignancy is low on ofatumumab, and when followed for over 4 years, the expected rate of incidence of malignancy stays low, and there is no significant increase. Finally, and this is really a very important topic now, and another topic where we have changed our whole concept of approaching it as far as managing our MS patients, it's the topic of pregnancy and monoclonal antibodies. And remember that before, we used to stop the disease-modifying therapy at least a month before allowing the patient to get pregnant. And sometimes the patient would not get pregnant for 6 months or a year. The average time for an MS patient to get pregnant, according to the study, is around 6 months. And during that period, without treatment, we used to get relapses and fall into trouble. So it would be ideal if we can have a disease-modifying therapy that we can keep until the patient gets pregnant, and then we know that pregnancy is protective against MS. And that's the case, and that's the concept that has changed over the last year or two related to the monoclonal antibodies. Now, we know already that the monoclonal antibodies do not cross the placenta until late in the second trimester. We also know that if B-cell depleting therapy are applied or given to the mother late in the second trimester and in the third trimester, and they cross, of course, the blood-brain barrier, they can induce B-cell depletion in the baby. At the same time, we also knew that for ofatumumab, the time for recovery for the B cell is around 24 weeks, which is around 6 months. So there will be a very prolonged period of protection during the pregnancy, even if the woman is not taking the treatment. And remember, recent studies have shown that the early B cells that recover are actually the naive B cells, which are not autoreactive, and that the mature B cells, which are autoreactive, take around up to 12 months to start recovery. So even then, we have some immune reconstitution that will protect the patient beyond the B cell count recovery. So this is a very nice graph showing how the antibodies cross the placenta. And remember, the fetus does not have antibodies. All the antibodies of the fetus are transmitted from the mother through the placenta. And this is the amount of IgG in the fetus, and we can see there is no transmission at all the first 20 weeks. And then we start having some transmission, and it's really maximal by around, or significant by around 26 weeks of gestation. So our monoclonal antibodies, if given, will not transfer through the placenta to the fetus before at least week 20 of 24. So let's look at those monoclonal antibodies. Let's look at the 3 B-cell depleting therapy and their half-lives. These are the half-life here, 16 days, 26 days, 22 days. And we know that any medication is cleared from the system within 5 half-lives. So if you look at ofatumumab, it is cleared from the system at 12 weeks. So if you give an ofatumumab injection today, and the lady gets pregnant tomorrow, in 12 weeks, ofatumumab is cleared from the system way before reaching 20 weeks and being transmitted to the fetus. So it's basically safe to keep ofatumumab until the lady gets pregnant. And moreover, ofatumumab is going to protect the lady from any relapses all through pregnancy and probably in the postpartum period. And this was actually confirmed by many pregnancy registry of the B-cell depleting therapy. This is the German pregnancy registry. This is the International Pregnancy Registry of rituximab by Professor Hauser, with 102 pregnancies exposed to rituximab, and there were no congenital anomalies. This is the ofatumumab pregnancy registry. I was part of this registry. We're going to present this data next month in the next American Academy of Neurology meeting in Boston. And by the 25th of September, 2022, we had already 118 pregnancies that were exposed to ofatumumab. Among them, 104 were prospective. And if you can see here on the right, most of these pregnancies were exposure around the last menstrual period or in the first trimester, the vast majority. So basically, patients that stayed on ofatumumab until they got pregnant. And the result is showing here. In the prospective case, we already have 30 with known outcome, 0 congenital malformation, normal spontaneous abortion. And in the retrospective cases, again, no congenital malformation. So among 44 pregnancies with no outcome on ofatumumab, there is no evidence of congenital anomalies by exposing the mother to the treatment within the 6 months before pregnancy or during the first trimester. And this is why all algorithms of treatment around the world are changing right now. This is, for example, the algorithm from the University of San Francisco. And if you look here, rituximab, ocrelizumab, of course, ofatumumab was not available yet. And the recommendation is to hold infusion while pregnant, discontinue contraception 4 weeks after the last infusion. So we're not waiting, like the label says, for 6 months or 12 months. 1 month after the infusion, and in the case of ofatumumab, anytime after the injection, the patient are able to get pregnant. And this is really a very major advantage for us, not running the risk of stopping the treatment, the patient not getting pregnant immediately, and then running into disease reactivation. Breastfeeding, another major area where our whole concept of management has changed over the last 2 to 3 years. This is the WHO recommendation. It's a strong recommendation that exclusive breastfeeding is recommended up to 6 months of age. So we should not really deprive the mother of this possibility if we can. And remember, breastfeeding is good both for the mother and the fetus. For the fetus, it decreases the autoimmune disorder, improves cognition, decreases the postpartum infection. For the mother, it decreases the risk of many diseases, including ovarian cancer, diabetes mellitus, breast cancer, and so on. And of course, there is the issue of the pregnancy, the breastfeeding, able to protect probably exclusive breastfeeding from postpartum relapses. So if we have the chance to use a disease-modifying therapy in the 6 months after delivery, while the mother is breastfeeding, that would be ideal. In the past, we used to have two-way. Shall we allow her to go on a disease-modifying therapy, control the high risk of postpartum relapses, and sacrifice breastfeeding? Or shall we go with the breastfeeding, but not start disease-modifying therapy and run the risk of postpartum relapses? Nowadays, I think we are beyond this problematic choice, and recent studies have shown that we can have both at the same time. So if you look at the label of most medication, most of the medication, the current label says no breastfeeding. Few exceptions are interferon, glatiramer acetate, and interestingly enough, ofatumumab. Ofatumumab label in the EMA label actually is the only monoclonal antibody with a label that allows breastfeeding, and I will discuss it in a minute. So the recent studies have went ahead and looked at the concentration of this monoclonal antibody in the breast milk of the mother, natalizumab, rituximab, ocrelizumab, and turned out to be that these concentrations are extremely low, 1 in 200 or 1 in 240 of the maternal serum level. So it's extremely low. And remember, these are proteins. So if this very, very low concentration are absorbed by the fetus through the breast milk, they will go into the GI and they will most likely be destroyed within the GI as any protein. This is why you cannot give monoclonal antibodies orally. So we are shifting now into the concept that yes, we can use the monoclonal antibody while lactating. And this is another study where they measured actually the monoclonal antibody level, in this case, natalizumab, in the fetal serum while breastfeeding, and they showed that the concentration is extremely low. They followed those patients on natalizumab and B-cell depleting therapy, those babies that fed on the breast milk of their mother while their mother was being treated with monoclonal antibodies. They followed up to 1 year, and there was no adverse event and no abnormal cognition. So the conclusion here is that it's probably too conservative not to breastfeed on monoclonal antibodies. So nowadays, we're moving more and more toward resuming monoclonal body after delivery and allowing the patient to breastfeed. And as I mentioned, this is the EMA label for ofatumumab. Ofatumumab could be used during breastfeeding if clinically needed. Now, remember that the first 5 to 7 days postpartum, the mother excretes colostrum, not the initial milk, the real milk, but colostrum. And colostrum is very important because it contains a high number of antibodies and is important to protect the baby from infections. However, because of its high content of antibodies, there is the risk of the monoclonal antibodies going through this colostrum in a higher concentration than the breast milk. So it's always advisable that if you want to start a monoclonal antibody, including ofatumumab, while breastfeeding, always start it 1 week after the delivery until the whole colostrum is exhausted and the normal breast milk start flowing. So in conclusion, for my presentation, when we compared ofatumumab to teriflunomide, it was highly effective, much more efficacious than teriflunomide, with almost 50 to 60% reduction in the annualized relapse rate. The MRI activity was almost completely suppressed, with almost 90 to 97% suppression of all GAD-enhancing lesions. Even the new T2 lesions were suppressed and reduced by almost 80 to 85% compared to teriflunomide. Disability worsening was reduced by almost 1/3 on ofatumumab compared to teriflunomide. The concept of PIRA is becoming very important to us because this is what we call the silent killer or the silent disability progression early in the disease. And we've shown here with the ofatumumab, like with the other B-cell depleting therapy, that they are superior in controlling PIRA compared to the lower efficacy medication. The safety of ofatumumab was excellent, very comparable to teriflunomide. And as I mentioned, now we have this very high efficacy medication with an excellent safety efficacy balance, allowing us to using them early and benefit from their efficacy. And finally, the new concept of pregnancy and breastfeeding. We are allowing now women to get pregnant while on ofatumumab, of course, stopping it once they test positive for the pregnancy test. And we are allowing women to breastfeed after the first week postpartum while on the monoclonal antibodies. And remember, ofatumumab actually has the label for breastfeeding with the European label. Thank you very much.
Thank you, Dr. Yamout, as usual, for an amazing presentation. And here is the invitation to our 8th Menectrim Congress that will be held in Abu Dhabi. So we'd like to extend the invitation to all those interested in multiple sclerosis. And please allow me to take a few questions. So the first question, the patient population in Asclepios trial were patient treated with prior DMT or treatment naive relapsing remitting MS patients?
Yes, this is a very important question. In the Asclepios trial, only 40% of the patients were treatment naive, while the remaining 60% had previous treatment. And if you compare that, for example, to the OPERA trial of ocrelizumab, where almost 70% of the patients were treatment naive. So the population in the Asclepios trial was a little bit more advanced as far as MS. And this is why I said initially in the presentation, you cannot compare different trials once you are not controlling really for all of those variables that can make a big difference in the outcomes.
Another question, what about the dose of anti-CD20 monoclonal antibody and specifically ofatumumab in obese patients? So do we change the dose? Does the weight affect the dose of the patient? Do we need to do some dose adjustment on those patients?
No, I showed the study by Hauser that showed that irrespective of the weight from below 60 to above 84 kilos, the B-cell depletion was almost complete because of the monthly injection. We're not giving injection every 6 or 9 months, it's being monthly. And this is why the B-cell depletion is significant enough as to not be affected by the body weight. So for ofatumumab, there is no need to worry about the body weight.
Another question regarding the risk of infection. So we know B-cell depleting therapy, anti-CD20, they increase the risk of infection. So as all immunosuppressive drug. So what is the rate of infection with ofatumumab, not only from clinical trial, but also from your practice?
And from my practice, we've been using B-cell depleting therapy now almost for maybe 13 years, Maya, right?
Right.
And yeah. And we have probably around maybe 300 patients by now on B-cell depleting therapy in our practice. And maybe out of all those cases, I can maybe remember only 1 or 2 cases that has really very severe infections. But otherwise, the B-cell depleting therapy are quite safe as far as infection. And even I've had patients, we've used some patient on the initial B-cell depleting rituximab for almost 12, 13 years now. And we haven't seen any significant infections. So I would say, again, the rate of infection is quite low. And the reason is obvious. The reason is we are only depleting a very small component of the immune system, which are only the B cells, while everything else, the T cell, the neutrophil, the lymphocyte, like I showed you, the other lymphocyte, everything else is still preserved. Even the innate immunity is preserved. And this is why we have such a very good infectious profile, as opposed to medication that will suppress, for example, all the lymphocyte. And at the same time, there is the evidence of the immune reconstitution, which can allow the B cells to recover without being autoreactive. So because of all of these reasons, the infection rate with the B-cell depleting therapy and ofatumumab is quite low. And in my experience, like in the trials, we've rarely really encountered serious infections.
Another question. So we know that ocrelizumab, the other anti-CD20 monoclonal antibody, is approved for the treatment of progressive MS. We know that ofatumumab doesn't carry this label and was not probably tested in this population. So do you think that we can use it, we can extrapolate this efficacy of ocrelizumab in progressive MS for ofatumumab and use that in the future probably for progressive MS, whether active or inactive?
Yeah, this is a very important point. As far as I'm concerned, all B-cell depleting therapy have a similar mechanism of action, similar efficacy. They are depleting B cells. So I don't see why, with the complete B-cell depletion down to zero with all of these B-cell depleting therapy, we should have different mechanisms of action or different outcomes. Now, when it comes to the ocrelizumab and why is it that it has the only approval for PPMS, the reason is because it was the only trial that was done in PPMS, taking into account that in the Olympus trial of rituximab, the population was completely different. They were much less active. They were older. So when they did the oratorio trial of ocrelizumab, they selected patients that were younger and more active. And this is how we got the positive results. So these positive results, if you go into the oratorio study and look at the subgroup, the ocrelizumab efficacy is mainly in the patient that are still having active disease. So either relapses or inflammation, new gut enhancing lesion. If you remove those two parameters and look at the patient that are completely inactive, we don't see any efficacy. So even in the label of ocrelizumab for the primary progressive, and we are still dealing with a medication that predominantly is anti-inflammatory effect. And in that respect, I think all the B-cell depleting therapy are going to have a similar efficacy and a similar outcome once we're using them for active PPMS or active SPMS. Now, remember, monoclonal antibodies do not cross the blood-brain barrier, and the progressive process is mainly inside the brain, either in this meningeal germinal center of B cells, or maybe in the smoldering plaques in the white matter that are delivered by microglia. So in the future, the way I see how we're going to be tackling this issue of progressive MS is by an agent that can cross the blood-brain barrier, can tackle the B cells and the microglia, something maybe like the BTK inhibitors, for example. We'll have to look more into the data in the future. How effective are they in inactive progressive MS, not MS that is active? And I think we have many trials ongoing now that might give us this answer. So in short, a short answer would be that I think all B-cell depleting therapy will have the same effect on active PPMS and active SPMS. And actually, in our practice, especially with people that do not have any reimbursement, we've always used rituximab as a cheap B-cell depleting therapy for patients that were having progressive MS.
Another question, what about the washout period after natalizumab? So when we want to shift a patient from natalizumab to ocrelizumab, what is the washout period? And the same question for the shifting from dimethyl fumarate to ofatumumab.
Right. Let's start with natalizumab. Now, natalizumab and fingolimod both are what we call lymphocyte trafficking agent. They interfere with the trafficking of lymphocytes. So natalizumab will block all lymphocytes from going into the blood-brain, and they will accumulate in the serum. The problem is once you stop it, within probably 8 to 12 weeks, you have a rush of all of this lymphocyte inside the brain because the gate has opened suddenly, and you get a rebound significant inflammation. So nowadays, we're avoiding that by having a washout period for natalizumab with all agent, not more than 4 weeks. However, the only problem with that approach is the issue of PML. So you don't want to have a patient on natalizumab having a smoldering PML that has not shown yet very clearly, and then put them on a B-cell depleting therapy of ofatumumab, because then you have an irreversible B-cell depletion that will go for 24 weeks. And this will be very detrimental immunosuppressant if PML is already present. So we don't want that. Same for alemtuzumab, same for cladribine. So the recommendation is 4 weeks washout from natalizumab, but before that, you do an MRI, and the MRI should have a flare, GAD enhancement, and diffusion-weighted imaging, which are the way you can detect the very, very, very early PML. This MRI should be read by an experienced neuroradiologist and compared to the last MRI, and make sure there are no suspicion of PML. And what we do also, in addition, we do a lumbar puncture and check for the JC virus PCR in the CSF. If I have those two things that are reassuring, then for me, the washout period for natalizumab should not be more than 4 weeks, because after 4 weeks, as I showed, within 1 to 3 weeks, ofatumumab will deplete the B cells. So by that time, I will not run into the problem of the natalizumab rebound activity, which is 8 to 12 weeks. Now, for dimethyl fumarate, it's a different story. Dimethyl fumarate, of course, it's a drug that can deplete the lymphocyte, producing a mild lymphopenia, not more than 30% reduction in the lymphocyte count. So for me, for dimethyl fumarate, there should not be a very long washout period. Within a week or 2 weeks, we can shift immediately as long as my hematological parameters are normal. So I have a normal blood count and, of course, my hepatological marker, which are the liver function. However, there is one exception here, and that is 6% of the patient on dimethyl fumarate develop a severe grade 3 lymphopenia. We still don't know why. And those patients with this grade 3 lymphopenia, most of them, this lymphopenia occur within the first year of treatment. And it does not recover very quickly. Sometimes it takes up to a year to 18 months to recover. So this would be the only category where I will be a little bit careful about the shifting period between dimethyl fumarate and ofatumumab. Usually I shift immediately within a week if I have a normal lymphocyte count, but in those patients with grade 3 lymphopenia, I would probably be a little bit more careful.
I still have 2 questions. So any NIDA data with ofatumumab?
Yes, I showed the NIDA already. We have a very high NIDA achieved, which is basically above 40%. And if you take the second year of the Asclepios trial, because you have to allow the drug to work during the first year, in the second year of the Asclepios trial, 90% of the patients were in NIDA. So 9 out of 10 patients is in NIDA. And this is really what we see with these high efficacy medication. And remember, with our high efficacy medication nowadays, our aim is always to achieve NIDA, not just the patient with relapses and having multiple lesions in the brain MRI.
Yeah, true. So if our final question, so when do you prefer to use ofatumumab instead of the other monoclonal antibodies? And do we have any cost benefit ratio comparison between these therapies?
Yes. Now, if we compare the monoclonal antibody, of course, natalizumab has the disadvantage of the PML. So in patients that have a high antibody index, JC virus high antibody, and usually above 0.9 or above 1.5, usually we try to avoid natalizumab. Natalizumab is a medication that will require the patient to come every month, every 4 or maybe 6 weeks to the hospital to take the infusion, which is sometimes cumbersome for the patient. It's being now mitigated with the new subcutaneous natalizumab that has just come to the market of the UAE right now, and it's already being used in Europe. For alemtuzumab, it has a high toxicity levels. So the safety profile with alemtuzumab is not as good as the remaining monoclonal antibodies, and therefore we reserve it usually as a third-line therapy if we're failing with the other thing. With the B-cell depleting therapies, I think they have a very good safety efficacy profile. As I mentioned, they have a very high efficacy, and therefore they would be my choice when I look at the monoclonal antibody, specifically with these drawbacks of the other ones.
Those were our questions, Dr. Yamout, for tonight. So thank you for accepting our invitation and for being with us despite your super busy schedule. So thank you so much, and you are always welcome.
Thank you and good night.
Good night.
Bye.
So now we will move to the second lecture by Dr. Hani Dimasi. So Dr. Dimasi is currently an associate professor of biostatistics at the Lebanese American University since 2012, with a PhD in biostatistics and a master of public health in epidemiology. He provides his students with enough theory to understand how statistics works, but he also makes them understand the application and utility of statistics in the health field, namely in advancing knowledge. And I was lucky to be one of his students. And Dr. Dimasi taught in multiple disciplines, nursing, pharmacy, biology, medicine, at different levels, the undergraduate, the graduate, the master's, and in different setups. He has also provided researchers in a variety of health-related fields with statistical as well as methodological and research design support. In the research year, Dr. Dimasi has contributed in a number of publications related to access to health services among refugees, nutrition, oral health, and pharmacy work environment. Dr. Dimasi will teach all of us tonight about network meta-analysis, its relevance, and its application to the multiple sclerosis field, and how it actually allowed us to compare different disease-modifying therapies. Dr. Dimasi, you are the most welcome, and the floor is yours.
Thank you, Maya. Thank you so much for having me, and thank you, everybody, for being here today. So my presentation is going to be about meta-analysis with a little bit of focus on network meta-analysis. And I would like to start a little bit with the idea of explaining what is meta-analysis. And typically you start with the definition of the word meta, which means beyond or after. So basically meta-analysis are done after other studies have been done. And what you do is you come and you look at these studies and you try to aggregate the information, synthesize these informations. So, well, regular studies that we are used to, the cohort studies, the RCTs, the point of information collected is at the level of the individual, the patient, something that usually is referred to as IPD, individual patient data. Meta-analysis, on the other hand, what they do is they don't look at this level of data. On the other hand, they're going to look at the point of other studies being the point of measurement. So how is meta-analysis similar to the type of studies that we usually read? Whether it's a common regular study, quote unquote, regular study or meta-analysis, the point that is always important to remember is that these studies are always triggered by a research question, an inquiry, a gap in knowledge that we would like to fill. And both meta-analysis and regular studies strive to fill this void of information. They both use statistical techniques and tools to come up with a p-value, to come up with an estimate of the outcome measure, and to come up with a conclusion. And at the same time, we need to remember that any type of study, including meta-analysis or network meta-analysis, is always subjective to bias, and therefore researchers have to be cognizant of that fact, and they have to address the bias as much as they can. So why meta-analysis and not just a regular study? The common reason for doing a meta-analysis is that there is a need for a larger magnitude of evidence. A clinical trial by itself is not most of the time enough to give us the kind of level of evidence that we need. And therefore, what we need to do is aggregate these multiple clinical trials together to come up with a more stringent conclusion. Not to mention that sometimes there is a lack of head-to-head comparison between different treatments, for instance, and that's where network meta-analysis come in very handy. So meta-analysis provides statistical significance. They provide higher power of analysis when you put together. I'm sure you're also familiar with the pyramid of evidence, and we've all seen that right on top of these pyramid of evidence, we have the meta-analysis. They provide a better estimate of our outcome measure. For example, our ARR, the annualized relapse rate, we got a much better estimate if we do a meta-analysis. And they give us a much narrower confidence interval. And also meta-analysis can allow us to answer the question if the effect of the treatment is constant over different population of patients, or do we have different effect for different group of patients, something that we may talk to about, which is called the the fixed effect versus the random effect. And I'll talk about this a little bit later. So very briefly, the different types of meta-analysis out there. Most of us maybe are very familiar with meta-analysis done on randomized clinical trials, but I have to mention that meta-analysis are they can be done actually on other designs, case control designs or cohort designs. And more we're seeing these network meta-analysis, which have been proposed by Butcher et al. And then Diaz et al. As a method of indirect comparison. When there's a lack of head-to-head comparisons, the network meta-analysis allows us to fill in the gap that has not been addressed by a single study. So here's just a brief example of what I mean by that. So a typical meta-analysis, you're going to aggregate different studies. For example, a drug A compared to a placebo in study 1, study 2, study 3, and then study 4. These are individual clinical trials, and there's a direct comparison every time drug A with the placebo. And what the meta-analysis would do, it will aggregate all these results to give you a one final overall, more precise estimate of what's the association between this drug and the placebo. On the other hand, the network meta-analysis looks at direct and indirect comparison. So for instance, you may have drug A compared to placebo. At the same time, drug A is compared to drug C, the placebo is compared to drug D, and then drug E is compared to D, etc. As you can see with the direct line, meaning that there is a direct comparison. What network meta-analysis does, it will allow us to compare A to D, A to E, E to the placebo. Therefore, you can compare any of these drugs to any other drug or any treatment to any other treatment indirectly using the network meta-analysis approach. So in short, a network meta-analysis estimates indirect effects. So when I say indirect effects, I mean that it hasn't been directly observed in a single study. Rather, we're going to use, as I showed in the previous slide, the direct between multiple studies to be able to estimate the indirect estimate. The direct and the direct comparisons could be synthesized to obtain a higher power and more precise. Just because you have a direct relationship between a drug and another drug, while you're doing a network, you can come back to this measurement that you have, measure, and get a better estimate of it. It produces, as I said, all pair comparisons that you're interested in. The nodes and the edges, so these round bubbles and these lines connecting in a meta-analysis, they will reflect the number of comparisons and contributions of these studies. Later on, when we'll get to the graph, I will come back to that idea. Sometimes people use colors in these graphs to point out to where there is a bias and the level of bias, and hopefully we'll come back to that. But most importantly, what network meta-analysis also allow you to do is to rank these treatments. And here there are two statistics that are used, something called the SUCRA and something called the P-best. P-best meaning the probability of being the best treatment, and the SUCRA is the service under the cumulative ranking graph. And I'll show you that in a minute. But one point to be kept in mind is that the rank itself doesn't tell you how strong is the association. So you have to look at the rank, but you also have to look at the measure of association, the reduction in the relapse rate, for example, the reduction in the risk of disability, okay? So before we talk about meta-analysis, I would like to spend few words about systematic reviews, because systematic reviews are a component of meta-analysis. And for me, I would like to have a clear idea of what do we mean by systematic reviews versus our usual review of the literature, or what is called a narrative review of the literature. A narrative review of the literature has two problems. One, it is subjective. And second, it lacks the synthesis of the data. So subjective means that when you're reviewing these articles, there is no clear criteria of what makes a study better than a study. Is it the size? Is it the quality? Is it both? And many times, and it has been documented in the literature, you may have different reviewers of the same literature come up with different conclusions because they're being subjective in their review. And in fact, sometimes they're not even aware of their own bias when they're looking at this literature. So that's the number issue, the first problem with narrative reviews. The second problem is as the number of studies increases and you have more and more comparison and more studies, sometimes it becomes very hard to conceptualize all this information together. And therefore, there is a need for a proper synthesis of all this information to come up with one conclusion. So on the other hand, systematic reviews are governed by clear rules. For example, what to include, what to exclude. And now, true, it's not immune to bias, but at the same time, you can evaluate the bias of the studies in your systematic reviews. And the level of importance of every study is totally governed by pure mathematical criteria. Meta-analysis provide transparent, objective layout of results. Now, systematic reviews can be critically appraised using some sort of guidelines. One of the most famous one is PRISMA, which refer to preferred reporting items for systematic reviews and meta-analysis. And the article that I have reviewed and prepared for this presentation actually is using PRISMA. And PRISMA was developed in 2009 by Cochrane authors. And they developed it over a previous version, which used to be called the Quorum. PRISMA is made of 27 checklists that the authors have to go through when they're doing their systematic reviews, and it ends with a 4-phase flow diagram. So quickly, I'm going to show you these 27 checklists. Here's a typical PRISMA. It starts with the title, the abstract, introduction. So you have questions about the introduction, questions about the methods that you're going to try to answer. And based on the answer, you will be able to evaluate if your systematic review was done properly, well. And therefore, you go to the results all the way down to funding with 27 items, as I mentioned. Then comes the flow diagram of PRISMA, which is made of 4 levels. First is the identification of the records. So you need to tell your readers how many records you were able to identify. And then out of all these records, second, how many were actually screened. And then after screening, you move into the eligibility, those studies that met the eligibility criteria. And finally, the studies that have been included in your systematic review. And I'm going to show you now a flow diagram that was used in this study. So this is the study that I'm going to refer to back and forth. It's the comparison of ofatumumab, and other DMT for relapsing multiple sclerosis and network meta-analysis. In this study, they did an excellent job of providing all kind of information that you expect to see in a network meta-analysis. This is part of their supplement material. So here is your flow diagram. And I said, you have the level of identifying the literature, then screening, then the eligibility, and finally moving into which studies they've included. And you can see they went from 13,000, they went down to screening the 13,000, they excluded 10,000, then they moved into 3,000, they excluded another 2,500, and so forth, till they've ended up with 34 studies in their meta-analysis. And they tell you exactly how they looked for the literature, what were the databases that they looked for in different sources, making sure that they cover as much as possible all kind of results out there, whether they're published or not, whether they're positive, negative, or not. That's really the key of a good systematic review. You have to look at everything. So a meta-analysis typically has a protocol that follows 7 steps. Your first step is defining the objective of the study that you want to do. You remember I said the guiding principle of any study is your research question that you'd like to answer. That's where you start. You start with defining the objective. Then you have to move to what is the population that you're interested in. Then locating the study, screening and evaluating the study. abstracting the data, getting the results from the studies that you want to utilize, analyzing this. So that's where the actual meta-analysis is done. And you finish with the reporting and interpretation. So let's go through these steps one at a time. The first is defining the objective. Part of defining the objective, you're going to define your outcome of interest. So the lesions, the relapse, the disability. These are the kinds of outcome of interest that were present in the study. Next, you have to talk about the population. Do you have a specific age group? Is it all different age groups? Is it all genders, etc.? For example, in the study, they looked at our RMS and the RRMS population. Then you're going to define your treatment, and the study looked at ofatumumab versus other DMT. The outcome measured, so for each of these outcomes, how did they measure them? So for the relapse, where they used the ARR, the annualized relapse rate. For disability, they used the confirmed disability progression with the very specific definition, meaning how much of a change there is with a certain period of time, 3 and 6 months. And also you have to consider if there's potential confounding measures that you want to take into account while you're defining your objectives. And it might be an interesting thing to decide for whether you're going to go with a fixed effect model versus a random effect model. The study that we reviewed for this presentation, they decided to go with the random effect. So still, step number 2 is defining the population of literature. So here, when we're talking about population, I'm not talking about population of patients, I'm talking about the population of literature. How do you define these population? The first thing you want to do is you want to look at your inclusion and exclusion criteria. That is going to protect you from bias. Bias when it comes to the literature bias, actually. And again, I'm going to talk about this later on. And the criteria that was utilized has to be clearly provided to the reviewer, to the leader, to be able to tell what was done. The Appendix A and the Appendix B of the article exactly does that. In Appendix A, there is a table that goes under the eligibility criteria for systematic literature review for this network meta-analysis. And in Appendix B, they talk about the summary of the trials and the summary of the trial eligibility criteria. So let me show you this real quick. So this is table 1.6 from the supplemental material, and it talks about the eligibility criteria that they followed in their study, going from what population they picked, so the inclusion and who they included and who they excluded, all the interventions that they decided to include part of their review, the comparators. So sometimes you have a placebo, sometimes you have another treatment, the keywords they used to look for their study, and the study design. So all of those studies that they included are supposed to be the RCT regardless of blinding status. The next is the table that summarizes all the trials that they included. So these are all the trials that they included in their network. You can recognize the escalopiosis 1 and 2 that Dr. Yammoud mentioned a couple of times. The OPRA as well, 1 and 2 also was included. Each study, they tell you the exact sample size, the phase, if the blinding or not. So you see some of the studies were double-blinded, some were open-labeled, some were single-blinded. And the MS population, so as I said, most of them are RRMS, some of them are RMS, and then the duration of every trial. So this type of data allows you to look at what studies we're including when you're reading this network meta-analysis and have a good grasp of what was looked at. And finally, it's the summary of the trial eligibility criteria. Again, every study by itself, they tell you about the inclusion criteria that was utilized in this study and the exclusion criteria. Now, still in defining the population of the literature, you have to think about what to include. So the population includes the study designs. Is there any design that you would like to exclude? So for example, inferiority study. In fact, in that study, they actually say that Bocchio et al. Trial was excluded because it was a non-inferiority trial. So they're very open. They tell you exactly what they're doing. The patient characteristics also have to be defined, and we saw that in the previous slide. They exactly show you what population was included in every study. The treatment modality, whether intramuscular, subcutaneous, etc., they talk about this as well. The control group, is it going to be only a placebo or is it going to be an active control group? And obviously it was both. The outcome measures, and I talked about the ARR, I talked about the confirmed progression of disability, but also they did something extra in the study, is that they went back to their study and they adjusted the measures following the OPRA criteria because they wanted to do something called the sensitivity analysis, and I'll come back to that towards the end of my presentation. Blinding, there was double-blinded studies, there were single-blinded, there were open-label, and randomization. Was all the study randomized or not will also be included, part of the definition of the population of literature that will be included. So after all of this is done, you start working on step number 3, which is locating the studies. And that is probably the most frustrating and the most difficult part of the job, but it is very essential, very important that you make sure that you're doing the maximum you can. As we can see, they started with about 10,000 or even more articles to end up with only 39 studies. They had to make sure that they're including all possible studies. So effort should be in locating non-published data. It's not enough to look at only published data. You have to look at non-published data. You have to talk to your peer to see if there's any study that was done but not published. Look at special issue of journals. References of unpublished data and article can be followed up upon. Look into organization if they have some studies published within their own sites, white paper, thesis, master thesis, PhD thesis as well have to be reviewed to make sure that everything is included. Because a very important problem with a meta-analysis or systematic review is called publication bias. And that's where you fail to detect all the trials that are actually done. And that typically connects to studies that are unpublished. And the problem with that is that most studies that fail to show significance, they tend to be not published. That's why many times you have to go for a clinical trial registry, for example, to find these studies. Also in the literature, it's quite known that the size of the study will play a role in the publication. Studies that have small sample size suffer from not finding a place to be published. The language may also play a barrier. A bad search strategy might stop you from finding all the studies you're supposed to find. Also, international journals have a higher chance of including studies than local journals. So after you've done that, you go through a process of screening and evaluating the studies, because obviously not all the studies will meet the criteria. Not all of the studies actually are what you're looking for. So start with the screening of the database, eliminate studies that are either irrelevant or do not meet the criteria. When study is deemed adequate, however, the data is not published, you're looking for something, but they didn't publish it, it's essential that you try to reach out for the author and request the actual data. Each study should be reviewed for its quality, and whether the quality will play a role specifically when you come to something called the bias assessment. Reviewers of these studies should be blinded. They should be blinded to the authors, and they should be blinded to the result of the study when they're reviewing these studies. And though blinding might be viewed as a complication in the process, it's very essential to eliminate bias. So in the study, the meta-analysis that we're reviewing, that's what they did, and they talk about this in their methodology. They talk about 2 reviewers independently screen the title and the abstract. So you can imagine these 2 reviewers going through the 13,000 abstract and coming with conclusions. And what you do at the end is you compare the decision made by reviewer 1 versus the reviewer 2 to make sure that you're getting a fair evaluation of these abstracts. And when there is disagreement, they involve a 3rd independent reviewer. Something else that can be done is that scores could be allocated for every section of the study that were reviewed, and you can come up with some sort of a score, and using that score, you can decide on whether to include or not include. Some authors, they decide, for example, a minimum score should be a 3 out of 5 before the study goes into the meta-analysis. Scoring the articles that are going to go into the meta-analysis, there are techniques available. There's something called the Jadad, the Chalmers, and basically there's straightforward scoring techniques for the methodology, the randomization, etc. And you allocate a score, and then you come up with the total score. The point here is that you have to make sure that this is done by 2 independent reviewers, and there is a consensus that will be reached towards the end. After you've reviewed the article and you've decided on the studies that you're going to include in your meta-analysis, comes the job of abstracting these results. Because remember, at the end of the day, you want to take whatever results they found to put it in your meta-analysis. So here again, you're going to have 2 abstractors that are going to work together on doing the abstraction. They have to reach a consensus among them. And you may want to blind them towards at least the author of the study, because, you know, sometimes authors are very well known and you may feel bad about, you know, not including the results, or you may feel that these results are more trustworthy. Therefore, you try to blind your abstractor to the authors. So what do you abstract from these studies? You need an identification of the study, obviously, the design of the study groups, number of the groups, age and gender, diagnosis and treatment, length of the treatment, the test that was used, the p-values, the confidence interval, the sample size, and the details on statistical methods. Here's an example of what a data abstraction form would look like. Fill in the information about the study, and then over here, you would fill what the results, what are the numbers for group 1 versus group 2. And notice you can have results that are measured in terms of means and standard deviations, or you can have results that are measured in terms of numbers. So for example, ARR is based on numbers. How many relapses are we observing? Finally comes the data analysis part, where all these results are going to put in a specific software that analyzes results from studies to generate meta-analysis results. And typically what you're going to get is something called the forced plot with p-values and confidence intervals. You're going to get a test of heterogeneity. You know, remember I talked about fixed effect versus random effect. You get a test for that to know if you go with the fixed or the random. You also get a measure of the effect size that synthesizes all other effect size. So finally, you're going to report your results and interpret these results using a descriptive table where you're going to include all the relevant informations. And some authors show the results of the scoring of the studies, our graph in the inclusion, and that is also provided in the supplementary material that I showed you. Also part of your reporting, you have to address publication bias. So let's talk a little bit about what a typical forced plot, because basically what these are, what you look for in a meta-analysis is a forced plot. What do you expect to see in a forced plot? So I have here a laundry list of what you expect to see, but I think it would make more sense if I showed you through an example. So this is an example coming from gastroenterology in 2009, and that's your typical forced plot. The elements of the forced plot: 1, it tells you what it is about, what is the efficacy we're looking at. Next, you're going to get the names of the study. So this specific meta-analysis looked at 1, 2, 3, 4, 5, 6, 7 studies, and they're identifying the studies by the authors of these studies. Next, you're going to get a description of the numbers of individual in the treatment arm and the number in the control arm, as well as the number that actually developed the outcome. Here, the outcome is improvement. So for example, in study number 1, 9 out of 20 improved in the treatment arm and 3 out of 20 in the control arm. So you get all the detailed information study by study. Then you're going to get an aggregate of the sample size of all these studies. So by aggregating all these studies, we end up with 541 in the treatment arm, 354 in the control arm. As you see, compared to the individual studies, you're really getting a much larger sample size. Next, you will see a relative weight of every study, meaning how much every study is contributing to the meta-analysis, and this directly is reflective to the sample size. Larger sample size studies will have a larger effect size, contribution weight, and that is reflective by the square that you're seeing. Larger sample size gets a larger square, so visually you can tell which study has a larger contribution. And also you're going to get your outcome measure. In this instance, it was an odds ratio with the 95% confidence interval. Also, you're going to get a graphical representation of these odds ratios with their confidence interval. And the line in the middle is just a delimitation line telling you where no difference is occurring. So every time this horizontal line is crossing the one, you're losing statistical significance. And also to help you read better the results, down there on the x-axis, you're going to get a enumeration of what the value of the odds ratios are, and tells you that this part of the graph is favoring the control, whereas on this part of the graph, it's favoring the treatment. And finally, you're going to get the aggregate, the synthesized result of putting all these studies together. It's shown as a form of a diamond, but it doesn't have to be. And the point here is that this means this is an odds ratio of 1.63. The confidence interval is not crossing one, it's statistically significant. While if you looked at the individual studies, you would see that 1, 2, 3, 4, 5 of the study failed to detect statistical significance. And here you can see the advantage of making a meta-analysis. By putting all these two studies together, we get a better estimate with more precise confidence interval. Over here, what you're going to get is an overall test of the aggregate synthesized measure of outcome with the confidence interval. So the p-value is statistically significant, which was the same conclusion as the confidence interval not crossing one. You get a test of heterogeneity, and that is telling you if we think the effect that we're observing is actually a fixed effect or a random effect. And since the p-value is not statistically significant, it means that it's a fixed effect. Another thing you can look at is the I-squared, and as long as your I-squared is below 40%, again, this is an indication that it's in a fixed effect. Here I'm showing the Forrester plot from the study, the network study. It's a little bit different because they're not after aggregating all of them, and actually they can because it's a network. What they're after is comparing all the treatment versus ofatumumab, and that's what you're getting. So you're getting every treatment compared to ofatumumab. And where you are on this side of the curve, it means that ofatumumab is actually better. On this side, it means that it's worse. And when the confidence interval crosses the red line of 1, it means it is not statistically significant. And that is taken from the actual article, the results of the network analysis, and specifically the ARR. Something else you're going to get in a network meta-analysis is something called a network graph, which is similar to what I showed you previously, but in fact here, you're going to see a much more dynamic graph, and it's showing you what are the direct comparisons that are done. So the ofatumumab was only in direct comparison with the TARI, which, excuse me, I don't remember the exact name of the medication, but this medication was in direct comparison with others, and others with direct comparison with others. Obviously, most of the direct comparisons were done with placebo. And because we have this network of comparisons, they were able to compare their medication to all other medication. And again, remember the size of the node and the size of the rod is reflective of how many direct comparison. This is why the placebo is getting the largest node. All right, so after you've done that, you have to think about publication bias. How can you address publication bias? One thing that is easy to do is doing something called a funnel plot. And I'm just going to jump into what is a funnel plot. A funnel plot basically is going to plot on the y-axis the sample sizes of the study, and on the x-axis the effect measure. And we know that as sample size increases, the effect becomes more and more precise. And therefore, you should see less wobbling as you're going up. And therefore, you end up with a nice pyramid like this. That indicates that there is no publication bias. However, if you see something like this, where when you're looking at your inverted funnel or pyramid, you see there is an area over here that is completely empty. Well, this is indicating that when reviewing the literature, there was a lack of identifying articles with a smaller sample size with results on the other side of the risk ratio. So that would be an indication of a publication bias. Authors do tend to present their funnel graph. So this is an example of a funnel graph from the literature, and it's working exactly how you'd expect it to work. More on risk of bias. The authors of the article actually did something with the risk of bias, and it's according to the Center of Review and Dissemination Guidelines, CRD, which is published in 2010. And I'm just going to show you the results. So again, these are all the trials that they are reviewed. And every trial is reviewed in terms of these 6 potential bias. So you can read down there, A, was randomization carried out appropriately or not? And then you can see that for the majority, it's a lower risk. Now we've got some high risk studies. So for example, for B, was the concealment of treatment allocation adequate wala la? And this graph allows the reviewers to have an idea of how much every study bears in terms of bias. Similarly, you can use a network graph, but this time using the colors to indicate the bias as well. So that's an example. Last, I'm going to talk a little bit about ranking. So it's possible, as I said in the introduction, to rank the treatment to figure out which one is the best. And you have 2 methods. There's the probability of being the best, and there's also the SUCRA method, which is the surface under the cumulative ranking curve. And according to the literature that I looked, SUCRA appeared to be more trustworthy. So again, the authors did that. They looked at all the treatments, and they provided the mean SUCRA for each one and the probability of being the best for each one. Okay. Now, how does it work? Very simply, here's an example that I get from Cochrane. Here we have 5 different treatments, and therefore they can rank 1 to 5. Every treatment gets a probability of ranking first, or second, or third, or fourth, or fifth. And as you're adding up these probabilities for each treatment, they will add up to 1. So obviously, this first treatment has a very high probability of being the best. This 0.85, this is the probability of being the best, okay? But what you need to do is you take these and you do a rankingram where you're going to display graphically these probabilities. That doesn't do the SUCRA yet. To do the SUCRA, you need to do a cumulative. Yani this point, the next point, you're going to add the distance here up there, and you start building your curve cumulatively. Something looks like this. So these are the cumulative probabilities of ranking first. And what you do is you calculate the median or average probability of ranking first. And therefore, you get a better idea of which study probably has a higher chance of being the best out of all the treatments. Finally, it's also quite commonly done is to do a sensitivity analysis. And basically, sensitivity analysis is what if. So what if instead of having all these definitions and criteria that they have, what if they change them with the conclusion they reach be very widely changed? And they have a list of sensitivity analysis. I'm highlighting a few of them because for me, they're easier to look at. The third sensitivity analysis, what if they included abstract and posters? Would that change their results? What if they included other formulation? What if instead of using the random effect, they use the fixed effect? And the last sensitivity analysis, what if they only look at trial published before 2004? Would that change? And again, if you go back to the article we discussed, you will see that they provided with more analysis, more forest plots for the reader to look at these results and have their own evaluations of the analysis. So basically, this is it for my presentation. Thank you. I would like to especially thank Maya Zainuddin for inviting me, the IVPN Neuropsychiatry for holding this session, and Novartis as well. Thank you.
Thank you, Dr. Dimasi, for a very, very enriching presentation. And please allow me to take a few questions. So the first question, is network actually meta-analysis better than meta-analysis? So is it superior?
My best answer is that network meta-analysis allow you to answer questions that you cannot answer in regular meta-analysis. Remember, regular meta-analysis, you can only do it if you have the same treatment compared to the other same treatment, yani treatment versus placebo. However, you cannot do indirect estimation or evaluation if you're not doing a network. So really, the network meta-analysis solved a huge problem when there was no direct head-to-head comparison. So instead, I mean, you can imagine the study. Instead of doing ofatumumab versus every other one of these different treatments, which will take money, resources, time, and they could just do that by doing the network analysis, network meta. Yeah.
And for therapies comparison, so in network meta-analysis, we are comparing drugs and different treatment. Do these meta-analysis take into consideration the diagnostic criteria for the disease? For example, in MF, there are different diagnostic criteria. So do they take this into consideration?
So I would believe that the answer to that is in their selection and identification of their objective. Right at the get-go, right when they start, they have to decide at what to look for, what kind of population. And I think I showed you a graph where they had different, but most of them were kind of the same diagnosis, if I'm not mistaken. Probably Dr. Yamut has a keener eye than me in detecting these differences.
No, they usually take the same diagnostic criteria. So they usually have standardized diagnostic criteria. Yeah. So another question, what are convenient ways to produce sucra-based graph in a research?
Let me show you. Can I share for a second?
Yeah, sure.
Okay. So I'm going to share again, and I'm going to show you, trying to exit my, sorry. I'm trying to exit my. Okay, do you see that?
Yeah.
Okay, so this is coming from the Cochrane library. And what they're doing here is they're showing you how you can do the sucra. Basically, you calculate the probability of being the best for each one of these treatments. And as you're ranking them and doing the cumulative, then you can calculate the median for each one of them. That's my best answer. I mean, you have to be able to calculate the probability of being the best and the probability of being the second and the third and the fourth, etc., all the way down to all possible treatment. Therefore, then you can build your sucra, and then you can calculate the score, the mean sucra value.
Another question, is it always clinically relevant to follow up the aggregate mean in a meta-analysis to reflect on practice?
I'm sorry, I didn't understand the question.
So is it always clinically relevant to follow up the aggregate mean in a meta-analysis to reflect on practice? So can we always apply the result in our clinical practice of the network meta-analysis?
I would say, I mean, we never stop at one study. I think Dr. Yamut showed you a plura of research and more research and more research. And I think he had multiple meta-analysis in there. There was always addition. But I mean, yeah, I mean, you try to look at the latest in evidence provided, but we don't stop there. There was always new evidence adding.
And a final question, if there is any minimal or maximal number of studies that we can include in network meta-analysis?
I don't have a direct answer to that. Obviously, it would be probably not feasible if you end up with 500 studies. I mean, it will be.
Yeah.
But as you can see in this study, they started with thousands and they ended up with 39. You probably need maybe like 5 or 6 to do some sort of, because if you only have 2 or 3, then probably the number is too small.
Yeah. And those were all the questions, I think. Yes, so thank you so much, Dr. Dimasi, for being with us tonight and for accepting our invitation. And with Dr. Dimasi, very enriching presentation. Our first NeuroSTAT webinar comes to its end. Thank you for our esteemed speaker, Professor Yamut, Dr. Dimasi, for being with us tonight. Thank you, Novartis, for supporting this activity. And the big thank you goes for you, our attendees, for staying with us until the end. I would like to remind you that you will receive your certificate of attendance by email within 1 week from today. And if you missed any part of this webinar, you don't have to worry. Or if you would like to revisit the lectures, you can check our IVPN NeuroPsychiatry library, where we will post all the recording. So you can visit our library at any time and revisit the lectures. Also, follow us on our social media platforms and stay tuned for more NeuroSTAT series and other also educational activity after the holy months of Ramadan. Until we meet again, stay safe and have a good night.